This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here with Dr. David Bull, one of our CSAP 17 authors, who has agreed to speak with me today. David, can you share with our audience where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or maybe a usual week so they know a little bit about what you're up to?
Well, thank you, John, for the opportunity. I practice at the University of Arizona in Tucson, Arizona. My practice consists primarily of adult cardiovascular and thoracic surgery as well as critical care. So in an average day, I'm performing surgery in the setting of adult cardiac surgery, adult thoracic surgery, vascular surgery, and then also have obligations in the intensive care unit that I share with the anesthesiologist and the acute care surgeons, critical care surgeons at the University of Arizona.
I have asked you to share some of your thoughts on perioperative issues that affect all surgeons of all specialties. So we'll be discussing topics from CSAP 17 that are located in the perioperative category. Many of the topics come from CSAP 17 questions, but others will be from questions that were discussed by many of the CSAP committees, but were not selected for the final draft of CSAP 17, but I kind of remember a robust discussion, so I want to pick your brain about many of those, especially as they relate to problems that a general surgery may find themselves confronted with. An easy place to start is fluid and electrolyte management, which everybody says they understand, although I'm not sure we all understand all of it anyway. But lately it seems things keep changing, and the literature seems to now have many articles that support fluid restriction, not only in trauma resuscitations, but even in the perioperative period, including the operating room. What do you think about that? Is that good, bad, or ugly?
I think overall it's good. This movement towards fluid restriction is really based on enhanced recovery after surgery protocols, which have demonstrated that patients who receive less fluid typically spend less time in the ICU and less time in the hospital overall compared to those patients who received liberal amounts of fluids perioperatively. So today I would say the trend is towards goal-directed fluid replacement. That has to be individualized to the patient, but really I would characterize it as trying to replace just the volume that the patient has lost during the procedure or maybe in deficit coming into the procedure as they've been kept NPO before the procedure, but not replacing more than that. We found over the years that giving excess fluid carries its own risk of complications, including lung edema, peripheral edema, prolonged time on the ventilator, other issues. So I don't necessarily think of it as fluid restriction per se. I think of it as goal-directed therapy, individualized to a particular patient, and appropriate fluid replacement.
So once again, the goal is that magic word, euvolemia?
Yes, that's really the goal. We today think more in terms of euvolemia rather than giving every patient more fluid than they probably need.
David, we had an interesting discussion on this at M&M about a month ago, and the discussion went like this. It was from one of our older surgeons, not me, by the way, somebody else, okay? And they raised the issue that our fluid management, when you go back in history, was aimed at preventing renal insufficiency, which was what we were all afraid of a long time ago and actually still afraid of today. Is that a valid historical note on this?
I believe that it is. That certainly has been the major thrust of fluid volume replacement therapy in the past. We've learned, however, that achieving euvolemia is enough to prevent acute tubular necrosis within the kidneys. Once you exceed that threshold, giving extra volume, it's hard to demonstrate that giving volume beyond euvolemia is necessarily going to benefit the patient. Now, there are always individual examples, and again, I would caution the audience that it has to be tailored to the particular patient, but giving more volume than is necessary to achieve adequate renal perfusion, I think probably doesn't necessarily benefit the patient and may cause its own set of complications. But restricting the amount of volume to less than the patient requires is certainly not advisable either.
Is there one fluid type that's better than others for this approach?
Well, I think in the vast majority of circumstances, crystalloid fluid replacement is all that's required. I think that most colloid solutions today are used rarely and usually in an ICU setting. For most patients, crystalloid is sufficient.
Is there a benefit from a balanced crystalloid solution, or is just normal saline okay?
Yeah, that's always a subject of debate. I personally use plasmolite or lactated ringers. Sodium chloride is fine, I think, for most patients who have good renal function. I, again, would tailor it to the specific patient.
Let's go on to electrolytes. We have got a number of questions. It seemed to be a popular topic in CSAP 17, and there's a couple of questions about hypokalemia and trying to set the stage that my best efforts are being employed and I cannot correct it. Am I missing something else in the electrolyte panel?
Well, hypokalemia is a very common clinical problem. It's important to emphasize that 98% of total body potassium is located within the cells. Only 2% typically is extracellular. So a typical potassium concentration within the cell is about 150 milliequivalents per liter. In the extracellular space, it's typically 3 to 5 milliequivalents per liter, which is what we're typically measuring, for instance, with a serum potassium level. So that's the first thing to remember, is the vast majority of potassium stores within the body are located within the cells. The most common cause of hypokalemia is some form of coexistent alkalemia, which causes a shift of potassium into the cells as their storage depot, if you will, in exchange for hydrogen ion to maintain overall pH balance. So when I'm replacing potassium and having difficulty having the potassium, the extracellular potassium level rise, which is again what we can measure, I look at the bicarbonate level, and if the patient's level of bicarbonate, measured bicarbonate, is high, I know that I have to give additional potassium in order to reverse that hypokalemia, that the patient's deficit is often significant. So I think it's a matter of looking beyond just the potassium level and looking also at the bicarbonate level to see what the true overall potassium deficit is. Remember, for somebody who's got a serum potassium of 3.5 to 3, they're typically down 100, 200 milliequivalents of potassium. So it's probably more potassium replacement than you may realize initially to get that patient to a balanced potassium level.
If magnesium is low, does that need to be replaced before you can really get a normal potassium level?
Yeah, so coexistent replacement of magnesium with potassium will often be necessary to help totally correct their potassium level, absolutely.
Well, I've got a question that was addressed at many of the committee meetings, did not make it as a final CSAP question, but the issue is calcium supplementation. The discussion went, is it ever needed acutely when you're volume resuscitating an individual, or even taking somebody who comes in volume depleted and they're not hypotensive or anything, you just want to make sure that they get back to euvolemia? That's
a highly controversial topic, I would say.
That's why it's not in the final question session, I guess.
Yes. So in my own practice, granted that's often cardiac surgery, we do focus quite a bit on replacing calcium, but we find that the measured calcium levels will often fall for a patient on cardiopulmonary bypass, and that needs to be supplemented to allow adequate myocardial function. The issue often comes up in the general surgery setting or acute care setting, and a patient who's had significant blood loss and how much calcium to replace in that setting. I would say if the patient's hemodynamics are otherwise satisfactory with fluid or blood replacement, that's crystalloid or blood replacement, then calcium supplementation is not necessary. But if the patient's hemodynamics are compromised and their ionized calcium level is low, then I personally would replace their calcium. And I typically will do that in the form of calcium gluconate.
A follow-up question on that, which was a very emotional discussion, I might add, and that is, do you need an ionized calcium, or can you just follow the calcium level knowing that many of these people are going to be hypoalbuminemic as well?
Well, certainly once the patient's been in the intensive care unit for any period of time, they'll often be hypoalbuminemic, and that has to be taken into account when you calculate their true or their actual calcium level, which may be appropriate based on their serum albumin. But I use an ionized calcium because of the rapidity of turnaround with I can get the value, as opposed to a serum calcium, which typically takes longer in the acute care setting. So that's my rationale for using an ionized calcium. But you're absolutely right. For a patient who's been in the ICU for an extended period of time, their albumin levels often fall, and that has to be part of the corrected measure of the serum calcium, because that often may be actually normal for that patient based on their measured serum albumin level.
The other emotional discussion was, do I use calcium gluconate or do I use calcium chloride? You stated calcium gluconate. Do you have a reason why you use that instead of calcium chloride?
I like calcium gluconate because I worry less about the shifts of calcium that happen with calcium gluconate. You do it, administer it over a longer period of time, typically 10 minutes, which I think is satisfactory. Calcium chloride, I worry about spikes in the serum calcium occurring in the acute setting. So I feel that if calcium replacement is required, I feel more comfortable in terms of the hemodynamic consequences, particularly when other inotropes are going, with giving calcium gluconate.
And the other discussion that we had was this business about what you've already mentioned, is the patient who isn't resuscitating quite right and has gotten blood. The idea that calcium chloride will work quicker than calcium gluconate in that setting. Do you have any thoughts about that?
Well, that's the common teaching, and that's the rationale for giving calcium chloride. I don't dispute that. I don't think there's anything wrong with giving calcium chloride. My preference for calcium gluconate in terms of the way calcium is bound in that setting is its release is a little bit more predictable, a little bit more controlled, and therefore in some ways safer in the ICU setting.
Well, it's hard to leave a fluid discussion without mentioning acid-base balance. One of my favorite topics that I don't ever want to have to give a lecture on to the medical students or the residents, but CSAP 17 committees love this topic. And while we do have a couple of questions that present ways to interpret acid-base balance, do you have a practical way that you talk about when you're making those ICU rounds to assess the overall acid-base balance of a patient, which leads to that old question of whether a primary metabolic or respiratory cause is present?
I do. The way I teach it to our residents and fellows is to remember that blood overall is slightly basic, so it has a normal range measured pH of blood of 7.35 to 7.45. So less than 7.35, that is 7.34 or less, is considered acidemia, and 7.46 or above is considered alkalemia. So understanding the categories or the buckets, if you will, that the pH falls in helps initially. So the first thing I look at is the pH. So does the patient have a normal pH, that is between 7.35 to 7.45? Are they acidotic, that is their pH is 7.34 or less, or are they alkalemic, meaning that their pH is 7.46 or higher? So that's the first thing to look at. The next thing I look at is their PCO2. So remember that for every rise in CO2 of 10 millimeters of mercury, there should be a commensurate fall in the pH of 0.08. So pH and CO2 move in opposite directions. So if the pH is low, that is 7.32, and the PCO2 is high, 50, because remember normal PCO2 is approximately 40, so the PCO2 is 50, then virtually all of that acidosis, remember we're below 7.35 now, so we're acidotic overall, but all of that acidosis can be explained by the respiratory component, that is decrease in ventilation with the rise in the PCO2 to 50. So that's the next thing that I look at. And the flip side of that would be if the PCO2 is low, that is the PCO2 is 30, and the overall pH for the patient indicates alkalemia, that is their pH is 7.52, then virtually all of that can be accounted for by just the change in ventilation. If the overall pH indicates acidemia and it cannot be explained by simply the change in the PCO2, I then look at their bicarbonate level. If their bicarbonate level is then low, remember normal bicarbonate level is 24, so if they're 20 or less, then they typically have a mixed component that is some decrease in ventilation leading to a rise in CO2, as well as a metabolic component, an introduction of acid into the system as a result of hyperperfusion or other etiologies. And you can work through all of these different permutations, but essentially, really, I break it down into respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis. The tricky part actually comes when the pH is in a normal range and there's some degree of compensation. But in most patients, that compensation is not necessarily complete. So the trick is to realize that the trend in the pH, that is some acidosis or some movement towards a decrease in pH, perhaps 7.35, 7.36, and there's a decrease in the PCO2 indicating that they otherwise would be alkalemic, but instead they're acidotic. That suggests that they have a metabolic acidosis, and that trend away from normal of 7.4 will indicate to you what is the primary process. So in that case, it would be a metabolic acidosis that's being partially compensated for by an increase in respiratory rate in an effort to blow off CO2. And we could talk for an hour just on that topic, but I look first at the pH, next at the PCO2, and then at the bicarbonate, and usually within a minute or less can figure out, is this a pure respiratory acidosis, pure respiratory alkalosis, pure metabolic acidosis, metabolic alkalosis, or a mixed picture.
And I guess the other thing I would add, and it's why giving a lecture on this topic is so almost worthless, is the best way I know how to do this is to look at everything you just said, sit down with a pencil and work it out, and usually you can figure it out at that point.
Yeah, and actually once you're used to looking at blood gases on a regular basis, it becomes second nature and you can actually do it quite quickly.
Yeah. Okay, well, let's leave our fluid and electrolyte discussion and let's talk about some specific perioperative topics. So I'm going to lean on your CV training to help us as general surgeons manage two scenarios. So the first is when you have a patient who you're working up for a planned, needed operation, and they're undergoing a diagnostic procedure, and suddenly they develop chest pain, and lo and behold, they are identified as having a ischemic myocardial event. They're not in shock, but there is no question that they've had an insult. What should we do at that point?
So I would stop the procedure or not proceed with the procedure, depending on where you are in the process, and then immediately try to work up the etiology of the patient's chest pain. So the first thing to do is obtain an EKG and see if the patient has any evidence on the EKG of ischemic changes in their anterior wall, lateral wall, or inferior wall, and that's something that should be relatively straightforward to do. Then after that, I would send a stat troponin level and see if there's in fact evidence of myocardial damage, and that should show up quickly. And that's important because if the patient does in fact have an elevation in their troponin level, that suggests that actual damage to the myocardium is occurring or has occurred. And that then should warrant further workup. Sometimes patients do have chest pain that's just a result of a transient decrease in blood flow, but does not actually result in actual damage to the myocardium. But I think any patient having chest pain warrants immediately stopping the planned procedure and instead focusing on the etiology of that chest pain until it can be determined exactly what is the etiology in that particular patient.
So, David, if that first troponin is negative, but you do see ischemic changes on the ECG, what's your next step?
If I see changes on the EKG, that's concerning because that suggests that the patient may be in the beginning stages of what we refer to as an ST segment elevation myocardial infarction. So I would, again, not proceed with whatever the planned surgical intervention is, but obtain a second and third troponin level. The troponin level may not rise immediately depending on how much leakage of troponin there is from the myocardium. And so a second or third one would certainly be indicated in a patient who has changes on their EKG. An important point to make in this setting is we now have rapid screening tests for patients, particularly a CT angiogram of the coronary arteries. That can be obtained quickly. And if the patient has a low calcium score on their CT angiogram of their coronary arteries, that pretty conclusively rules out the standard etiology of chest pain, which is coronary artery disease. So these workups can proceed much more quickly now than they used to. If, on the other hand, the patient has significant calcium score on their screening CT angiogram, then I think further diagnostic studies, particularly a cardiac catheterization, is indicated.
Ultrasound play a role in this at all?
It can. A transthoracic echocardiogram obtained at the time can indicate if there's new onset of any wall motion abnormalities. Those often are more useful diagnostically if the patient has a prior echocardiogram to compare it to. But even if that's not the case, a patient with normal wall motion is reassuring, at least that significant myocardial damage has not yet occurred, but is not by itself a standalone test that we can rely on to say the patient doesn't have a possible ischemic event which is evolving.
Okay, and do they get any antiplatelet drugs or heparin at this time, or do we need to wait for a definitive diagnosis?
I personally will always give the patient aspirin, sublingual, in that setting, and then I have a low threshold to start heparin. If there's a contraindication, obviously you should wait, but if there's not, then I would start heparin, err on the side of caution, and then obtain the full set of diagnostic studies, troponins, screening CT angiogram of the coronary arteries, cardiac catheterization if necessary to definitively understand what's going on. Remember that cardiovascular disease is very common in the United States, so those types of events, perioperative chest pain, should be taken very seriously because often that's the setting when their ischemic heart disease is diagnosed.
Okay, well, the second scenario is that patient who has just undergone a major general surgical procedure. Everything went fine in the operating room. They're in the PACU. They wake up and they complain of post-op chest pain. An ECG is obtained and you've got ST changes. What happens then?
If the patient has changes on their EKG, I would take that very seriously and assume that the patient is having an ischemic event until proven otherwise. So again, I would obtain troponins. If there's not a contraindication, there shouldn't be to giving the patient aspirin immediately. I would give them nitroglycerin as well, as long as their hemodynamics allow for that. And then if there's not a contraindication, start them on heparin. And then would like to obtain a cardiac catheterization if that's possible to rule out significant coronary artery disease.
So this flurry of activity that happens in the PACU every once in a while with this kind of patient to get them to the cath lab is the right thing to do?
I think so, because if the patient is in the early stages of an acute myocardial infarction, being in the hospital actually gives us a significant head start on the patient in terms of getting to the cath lab and then making an intervention within 90 minutes, which usually can abort whatever process otherwise would be underway. So I would have a low threshold about getting that patient to the cath lab, because today stents can be easily and readily placed if a stenotic lesion is found, and that can completely reverse the ischemic process, if you will, chain of events, and keep that patient from suffering significant myocardial damage. So I would have a low threshold to have the patient have a cardiac catheterization. Most hospitals in the United States, it's a very safe procedure and can really be life-saving for many patients.
Well, maybe I should ask this first, but obviously there's all sorts of tools for cardiac risk assessment for major general surgical procedures. But if you've got a normal history and a normal physical exam and nothing else, do you need any ancillary tests in that patient?
Generally not. So the history, as we were taught in medical school, is actually very important. It's the basis for all further decision making. In that setting, in a patient who doesn't have risk factors, they're not a smoker, not diabetic, they're not obese, they don't have myocardial history, obtaining a lot of extra diagnostic studies really doesn't yield much in the way of significant information. So no, a lot of additional testing would not be required.
Let's move on to another topic that always evokes discussion, and that is what to do when you have a patient on heparin and the platelet count falls. What should we be doing?
The concern in a patient who has a significant fall in their platelet count, which I define as a decline of more than 50% relative to their initial platelet count at the time of admission, or an absolute fall in their platelet count to less than 50,000, is a significant concern to me because it raises the possibility of heparin-induced thrombocytopenia. So that should always be a clinical diagnosis. And if you suspect in a patient who's receiving heparin, this typically occurs after the patient's been on heparin as early as 3 days, sometimes even before that, been exposed to heparin previously. But more often, in the 5 to 7 day range. But if they have a platelet count, a fall in their platelet count of more than 50% compared to admission, or absolute value less than 50%, I immediately stop the heparin and will switch them over to a direct thrombin inhibitor.
Now, you mentioned the timing, so if it's less than 3 days and they have that 50% fall, then you don't consider that at risk for heparin-induced thrombosis?
No, I do.
Okay.
I do. I'm just saying that the typical setting, the classic setting, if you will, is 5 to 7 days after the initiation of heparin, but it can occur at any point. So vigilance is required at all times in patients on heparin. Today, heparin is used frequently in a variety of settings. So patients are often exposed to heparin through prior hospitalizations, other interventions. So these patients are often not heparin naive, and they may see an immune response to heparin exposure in the form of heparin-induced thrombocytopenia within a couple of days of starting heparin. So the time course in and of itself, I don't think is nearly as significant as the fall in the platelet count. If you see a fall in a platelet count of more than 50%, it should always make you think that the patient may have heparin-induced thrombocytopenia if they're actively on heparin.
So in your world, the idea that there is two types of hit 1 and hit 2, may not play as big a role. Is that fair?
I would say that's fair. I mean, heparin-induced thrombocytopenia 1 is typically described as a non-immunologic form of heparin-induced thrombocytopenia, if you will. Type 2 is typically classified as having the direct immune component to it. But in a practical sense, I'm always concerned when that platelet count falls in a patient on heparin. So I don't necessarily distinguish between so-called type 1 and type 2. I'm always concerned about it. If I see it, then I will turn off the heparin and, again, get them on a direct thrombin inhibitor.
You mentioned it's a clinical diagnosis, and I can see how you're doing that. Do you go ahead and try to prove that they have heparin-induced thrombocytopenia type 2, which is the autoimmune?
I do. So typically what I'll do is I'll stop the heparin and then put the patient, my own practice is to put them on argatroban. And then once they're on argatroban, and I like argatroban because it's primarily hepatically cleared, and so for patients who have renal dysfunction, I think it's easier to manage. I have them on argatroban. I do not give them platelets, and I don't put them on warfarin, so I just have them on argatroban. And then there's two tests that typically we use. So one is an ELISA, an enzyme-linked immunoassay that is very sensitive for the detection of heparin-induced thrombocytopenia, but not as specific. So it's a good screening test, and if that comes back positive, typically expresses an OD ratio greater than 1, then I'll go ahead and get a serotonin release assay, and that's typically the confirmatory test. But in my institution, that can take several days. And so I will get the ELISA test initially, because that will typically return to us within 24, 36 hours. More rapid turnaround, the serotonin release assay can take 5 to 7 days.
Now, let me ask you a controversial question that always occurs in our SICU. So the ELISA is negative, and some physicians insist that we still need a SRA, or a serotonin releasing assay, in that patient. How do you feel about that?
That's a tough question. I think it would depend on what your threshold of suspicion is, but the ELISA is generally, in most laboratories, very sensitive. So I think in the setting of a negative ELISA, my own practice is to assume that the patient does not have heparin-induced thrombocytopenia. I'm more concerned in the other direction, which is that the ELISA is positive, and then I still go ahead and confirm that suspicion with an SRA. I don't rely on the ELISA to tell me definitively that they have. To me, it doesn't prove that they have heparin-induced thrombocytopenia. It's a screening test. So I will not label a patient and treat the patient as if they have heparin-induced thrombocytopenia unless I have a positive SRA. My own practice would be if they have a negative ELISA, I don't proceed on to get the serotonin release assay.
I happen to agree with you wholeheartedly, but I usually lose that discussion or argument, especially with my vascular surgeons who tell me that they're more worried about thrombosis than bleeding. So
yes, I've been in those same discussions, so I understand.
Now, let me ask you another question. You said you use a direct thrombin inhibitor. You prefer argatroban. And while it's not hard to monitor or to administer, it does require some attention. It is the only drug the FDA approved for this treatment. Have you considered using some of the oral direct thrombin inhibitors that are currently available?
I have not, in my practice, done that. I know that others have, but I personally have used argatroban. It's something I feel comfortable with, understand sort of the nuances of it, one of them being that it will result in a rise in the prothrombin time and the INR as a result of the patient being on argatroban. So you have to take that into account. The direct oral inhibitors, I do not have as much experience with in this particular setting.
Well, let's take another topic with anticoagulation, and that's bridging with anticoagulation. So I've got a elderly patient with AFib. They're on warfarin, and they need a cholecystectomy. What do you recommend I do with his anticoagulation?
What I would do is measure their CHAD score. Now, CHAD score, CHAD is an acronym for a series of measures of clinical status that predict likelihood of stroke in patients with atrial fibrillation. So it's an acronym looking at whether or not the patient has a history of congestive heart failure, hypertension, if they're over the age of 75, if they have diabetes, and a prior history of stroke. And so a CHAD score of 0 to 2 typically indicates low risk, in which case I would just stop the warfarin. 3 to 4 is typically considered moderate risk. If they're 5 to 6, then I think the patient needs to be bridged with either unfractionated heparin or with enoxaparin, and then that will be continued as the patient comes off of warfarin. And then that can be stopped. In the case of unfractionated heparin, that can be stopped about 6 hours in advance of their surgery. Enoxaparin, I would stop 24 hours in advance of the surgery. The patient has their surgery, and then depending on an assessment by the surgeon of their risk of bleeding, the unfractionated heparin can be started at 24 hours in most circumstances. The enoxaparin, I would wait to start until 48 to 72 hours. Once those anticoagulants are in place, then you can restart the warfarin, so typically at 24 hours for the warfarin.
Now, the addition to the CHADS-2 score that has appeared in certain guidelines is the risk of bleeding. Do you use any calculation to assess the risk of bleeding in an individual patient when you're deciding to bridge them?
I tend not to. I'm more, as you were alluding to earlier, more concerned about the potential risk of stroke. So I focus, honestly, more on that.
Now, you mentioned you don't have much experience with new direct oral anticoagulation or coagulants, but the new guidelines suggest that they may offer an advantage when you need to bridge something. Do you have any experience with that?
Yeah, so the newer agents, I assume you're referring to Pradaxa, Eliquis, those types of agents?
Yes.
Yes. I do have a lot of experience with that. Typically, patients who have atrial fibrillation will come in to see me for a procedure, and they'll be on those agents. That's very common. Typically, what I do is, again, get their CHAD score, calculate it myself. If their risk is low, I'll stop those agents well in advance of their surgery, typically 5 days. And then if their risk is low, I don't substitute another agent in because they are at increased risk of bleeding. I'll do the procedure and then restart it following surgery.
And how, do you start it in a recovery room, which is one of the recommendations?
For the procedures that I do, no, because the procedures I tend to do carry an increased risk of bleeding. So I like to see that, and most of my patients end up having chest tubes, so I like to see that the output through the chest tubes is stabilized and is at a low level, and then I'll restart those agents, or even wait until the chest tubes are out. I want to emphasize that I actually will calculate what the patient's potential stroke risk is, which is really what we're worried about here, and based on whether or not they have a history of congestive heart failure, hypertension, they're over the age of 75, they have diabetes, have a prior history of stroke. I really rely on that to try to estimate whether or not, or calculate whether or not I need to have them on another agent, or can I just hold their anticoagulation throughout the course of the procedure and then restart it afterwards. And also another thing I'll actually do is get an echocardiogram to see if they have clot in their atrial appendage or not, because that can also help guide you as to what the patient's risk of stroke is.
I'm getting a feeling that you would like us in this patient with a cholecystectomy, and let's put them on a direct thrombin inhibitor oral agent, and they have a moderate risk of stroke, that the recommendation and the minor procedure is cholecystectomy, so the risk of bleeding is not high. You would not necessarily have us follow the guidelines, which says essentially stop at 24 hours before the surgery and restart it in the PACU, given the moderate risk of stroke in that patient?
No, I would. I would do that.
You would do that?
Yeah. I think your question illustrates well that it has to be tailored to the specific patient. So I absolutely would do that. In the setting you described, absolutely.
So what about antiplatelet drugs? And what's your practice regarding that patient on dual antiplatelet medication for their coronary stents who needs an elective general surgery procedure? The literature seems to be all over the place regarding stopping both, keeping one on, deciding which one to keep on. Can you help us?
I think so. This requires a little bit of detective work to determine what type of coronary stents the patient has. So there's two types overall. They can be classified as what they call bare metal stents and then drug-eluting stents. So bare metal stents typically will receive dual antiplatelet therapy for about 6 weeks, after which the risk of thrombosis of a bare metal stent really declines significantly, and so they no longer need dual antiplatelet therapy after about 6 to 8 weeks. Patients who have drug-eluting stents, typically the recommendation is that they should be on dual antiplatelet therapy for at least 6 months following placement of a drug-eluting stent. So the first thing to do is understand what type of stent the patient has, because it's not uncommon for a patient to remain on dual antiplatelet therapy long after the indicated time frame has passed. So I see it commonly that a patient received a bare metal stent, typically in an acute setting referable to what we described earlier in our discussion, and yet the dual antiplatelet therapy continues. Nobody's actually stopped it. So a little bit of interrogation of what type of stent the patient has can really inform you as to whether or not this dual antiplatelet therapy is still indicated. If the patient has received a bare metal stent, again, they can be off their dual antiplatelet therapy after about 6 weeks. If they've had a drug-eluting stent placed and that dual antiplatelet therapy is continued out to 6 months, the ideal thing would be to hopefully hold off on an elective procedure until that time frame has passed. But if there's questions about it, the best thing to do, I always advise people to talk to their cardiologist and ask them, at what point do you think we can safely stop the antiplatelet therapy for this patient? But understand that all stents are not the same in terms of the need for dual antiplatelet therapy to prevent stent thrombosis.
Now, isn't there some literature that suggests that drug-eluting stent needs to be protected for longer periods than what you have just identified?
Well, this is where what you said earlier is so appropriate, which is the literature is all over the place on this. It really is, and it has to do with the type of drug that the drug-eluting stent is matched to. So, again, I think once you're at that level of investigation, consultation with a cardiologist, particularly the patient's cardiologist, would be helpful in determining, can this dual antiplatelet therapy now be stopped to allow the patient to have their elective operative procedure and then, if necessary, reinstituted after that. And if the operative procedure becomes more urgent, there are other alternatives, including having the patient on intravenous agents like integralin as they come off of their oral antiplatelet agents. That can be given to the patient to prevent stent thrombosis, can be turned off in advance of surgery, typically 6 hours. The patient can have their surgery, and then that can be restarted post-operatively. So there are ways to bridge patients even on dual antiplatelet therapy, especially in consultation with their cardiologist.
Well, another drug that brings questions in the perioperative period is statins. One is the elective operative procedure, and I'll add another one, and that is my trauma patients come in, they're on statins, they have a number of injuries, and the question is always asked, well, do we keep them on the statin or is it safe to stop it? How should we approach those two situations?
My overall approach is that in the acute phase of injury for traumatic patients, the statins can certainly be held. I view their role as more of long-term maintenance than necessary in the acute setting. So my personal practice is to hold the statins until the patient's through the acute phase, and then once they're able to take oral nutrition, then reinstitute the statins at that point.
And what about the elective operative procedure?
Well, for elective procedures, I'll continue the statins up until the time of surgery and then reinstitute them post-operatively once they're taking other oral agents.
But my cardiologist tells me that I'll make that plaque unstable.
Well, that's certainly a concern. I'm not sure that having the statins held for 2 days or 3 days is going to change the stability of the plaque, especially in a patient who's been on statin agents for months, if not years, prior to the interventions.
Glad to hear that. So I'll quote you next time I get into that argument, okay?
Good. Sure.
All right, so I also know you have an interest in nutrition. So in the Eris bundles that we now use for many different clinical conditions, can you help us understand the value of that carbohydrate load?
Carbohydrates generally should constitute about 60% of the nutrition that the patient receives. remember, carbohydrates are primarily the energy source for the patient, proteins and fats serving other functions as well. The amount of carbohydrates administered, I think, has to be taken into account or accounting for whether or not the patient is diabetic, whether or not they are stressed, if they're on steroids, etc. So the amount of carbohydrates administered, I think, has to be tailored to the particular patient's situation.
A follow-up question is, everybody worries about the diabetic and that carbohydrate load. Is that something we should be concerned about?
I think it is. Certainly in a critical care setting, I will decrease the amount of carbohydrate that I administer to a diabetic patient, a stress patient, patient on steroids. In the critical care setting, for patients who meet those criteria, typically what's going on is that they have ongoing endogenous production of glucose as a result of their own endogenous adrenergic systems being revved up, and they don't shut down that endogenous production if they're stressed or on steroids or diabetic. And so you need to decrease the amount of carbohydrates those patients get to avoid hyperglycemia or excessive production of CO2. And so I'll typically target carbohydrate administration in those patients at somewhere between 1 to 1.5 grams per kilo per day, which is lower than the recommended administration of carbohydrates, which is typically somewhere between 2.5 and 3.5 grams per kilo per day in a critical care setting. So I think you do have to, my own practice is to tailor it to the patient's own physiology to try to maintain relative normal glycemia and avoid excessive CO2 production.
One of the other things that it is suspected is that the carbohydrate load helps with insulin resistance. Is that something that we should be concerned about?
I believe that it is. I think that insulin resistance is a significant issue, so I am concerned about that, absolutely.
Well, just out of my own curiosity, so I mentioned the Eris bundles regarding the carbohydrate load, and I know there's one out there that many people use for esophageal resections. Is this something that has gotten into the practice of general thoracic surgery or cardiac surgery yet?
I would say not as much. I would say overall our approach in the setting of esophageal resection is we establish, most of those patients get a feeding jejunostomy, and we try to start at least trophic feedings early in those patients. And so they're receiving carbohydrates as part of the overall tube feedings, but we don't necessarily alter the amount of carbohydrates that we're giving them specifically because they've had an esophageal resection.
All right, well, there's another bundle out there, which is the central line bundle. Is it really beneficial to dress up like we now dress up when we put that central line in?
I believe that it is. My own experience and read of the literature is that ensuring sterility at the time of the insertion of a central line can markedly decrease the incidence of catheter-related bloodstream infection. So I am meticulous about gowning, gloving, wearing masks, hats, etc. Strict sterile technique with the insertion of central lines, absolutely.
Okay, now the Joint Commission has just come out with a maintenance bundle for central lines. I think it's more a common sense bundle. It talks about washing your hands. It talks about sterility when you're using the catheter and inserting an infusion. Do you have anything about maintenance of these catheters that tries to maintain the sterility that we establish when we put them in?
Yes, we do. So our ICU has protocols related to the maintenance of these lines. We tend to be very meticulous about changing the lines once they have been in place for 3 to 5 days. Obviously, ICUs get busy and you don't necessarily get the lines changed at 3 days for every patient. And then having sites for insertion can become a real issue in a patient, for instance, who is receiving TPN but may also be on ECMO or other forms of support. So not to minimize that, but if at all possible, we try to rotate line insertion sites on a relatively frequent basis. And in between, the dressings are getting changed every 12 hours so that bacteria, which the mechanism being migration along the course of the catheter, are minimized with dressing changes, administration of Hibiclens, and then reapplication of a clean dressing.
When you say you change them 3 to 5 days, is that a wire change or is that a new catheter?
We ideally like to place a new catheter. We have moved away from changing lines over a wire unless absolutely necessary, meaning that they don't have other sites. But our strong preference is to have new insertions at new sites.
Well, I get lots of flyers about different types of catheters, fancy catheters with antibiotics or antiseptics embedded in them. Are these worthwhile or just another excess cost in our healthcare system?
My own view is that those are specialty catheters that are indicated for very select settings. So, again, a patient who does not have many sites available for access, internal jugular veins are utilized, subclavian veins are being utilized. I very much try to stay out of the femoral veins as the source for any type of catheters for any period of time. So for those select patients in whom sites are not available, there may be, in my mind, a role for these types of specialized catheters, but in the vast majority of the patients, they're not necessary. What I think is of much greater utility is to rotate the line insertion sites on a regular basis. I think that does more than anything to lower the incidence of catheter-related bloodstream infection.
If you're rotating the catheters that much, are you worried about technical problems, i.e. pneumothorax or central venous thrombosis?
We always worry about that. Our protocol is to always use a site-right ultrasound system to identify the veins, and when you do it on a regular basis, you become quite comfortable with that. That has markedly reduced our incidence of vascular injury as well as pneumothorax. And so I think if you're using a site-right or other ultrasound technology, I think that you can markedly reduce the incidence of these types of complications, which we used to see much more frequently in the past.
And you use that device for both subclavian and IJ access?
Generally, I'm a little bit old school, so I feel comfortable placing the subclavians without ultrasound guidance, but sometimes our fellows give me a bad time about that. But certainly for any IJ insertion, I'll use the site-right.
I'm glad we both get comments about that. So I'm going to come back to fluid restriction. So renal failure, I know because of a lot of different reasons, still is a problem, and many of it can be related to the contrast that we use for our diagnostic studies. So in a patient that you know is going to get contrast, is there a protocol that you use to reduce the risk of acute kidney injury?
Yes, there is actually. So what I do actually is if the patient's getting contrast, and I don't worry about contrast in a patient who's got normal renal function and normal creatinine clearance, but it's the patients who are diabetic or have some other reason to have renal insufficiency that I worry about, because those are the patients who are at risk to go on to develop significant renal insufficiency, a fall in their creatinine clearance, or outright renal failure. And so what I'll do for those patients is, after they come back from the procedure, I will measure their urine-specific gravities, and if you measure them early, they typically are quite high, reflective of the contrast that's being excreted through the kidneys. And then with gentle, ongoing, continuous crystalloid volume replacement at a not excessive level, but appropriate level to maintain euvolemia, hopefully see a fall in their urine-specific gravity. Once that normalizes to about 1010, then I'll know that they've been adequately volume resuscitated without giving too much volume, and believe that the contrast has been cleared from the circulation. And in that circumstance, in the vast majority of patients, have been able to avoid complications from the receiving contrast.
So you don't use any of the drugs that some people recommend that might help prevent this problem?
Are you referring to N-acetylcysteine and dopamine, those types of agents? Or?
Yep, and sodium bicarb?
Not as much. I used to use those agents more in the past. I will occasionally use bicarbonate depending on a particular patient, but I've really moved away from using those adjunctive agents, if you will, and focus more on just judicious volume replacement, looking at the urine-specific gravities and seeing if we can clear the contrast that way.
Well, I'm sure you see a lot of patients with delirium in your ICU, but I'm also positive that many of your elderly patients who are on the wards also are affected with delirious activity, if you will. Can we prevent this?
I believe that we can. My approach to delirium is I actually believe that in many cases this reflects, number one, a lack of sleep that the patients are subject to in an ICU. You know, if you look at an ICU, if you're spending any time in there, it's really a high stimulation environment, and it's very difficult for patients to sleep. And patients don't sleep for 2 or 3 days, especially elderly patients. They can become disoriented and confused quite quickly. So we've really moved to trying to institute sleep as a therapeutic, if you will, understanding it's important for patients, and by doing that have seen a decrease in the number of patients experiencing delirium. Having said that, that's not the only etiology. A lot of our patients, even elderly patients, often are significant users of alcohol, and once they get in the hospital, they're not able to access alcohol as freely. That can lead to delirium. Patients are often on other medications as well. They may be on benzodiazepines chronically. If they're taken off of those, they can experience delirium. So lack of sleep, a change in their social drinking habits, failure of reinstitution of chronic medications they otherwise take, all can contribute to delirium in patients, especially in the ICU.
Let me ask, in that population where alcohol may be part of the picture, do you have any standard approach for treating a patient with alcohol withdrawal?
Well, my preferred approach is actually to give the patient alcohol, but that can be frowned upon in the hospital. So that's always a touchy point between me and some of the people in the hospital. Beyond that, if the patient's intubated, then I actually like to have the patient receive propofol if they're going through outright delirium tremens. I find that propofol is very effective in that circumstance and can obviate a lot of the potential morbidity mortality from delirium tremens. Otherwise, giving the patient benzodiazepines can sort of decrease the impact of the DTs, although not to the extent that giving them alcohol can. So it's a difficult problem. It depends on whether or not the patient's intubated. If they are, I'll give them propofol. If they're extubated, I'll typically give them Ativan, for instance, as an agent to help decrease the severity of the alcohol withdrawal.
Now, delirium happens. You mentioned ways to potentially prevent it, but other than being a problem for healthcare providers who are managing the patient, is there really any impact of delirium on the patient?
There's significant impact of delirium in patients after surgery, particularly patients in the ICU and especially elderly patients. So studies have shown that even short periods of delirium in the ICU can lead to long-term cognitive decline in patients. So it is a major public health problem that I think has been significantly under-addressed in the United States and something that I think needs much greater focus and attention. But studies over the last several years have demonstrated a connection between patients who experience delirium in the ICU, particularly following surgery, and later cognitive decline at 6 months to a year out. So it's a significant problem that I think we do not fully understand the gravity of.
When you're evaluating one of your patients pre-op, do you use any special tool to estimate the risk of that patient developing delirium postoperatively?
I do. So I find that delirium is more common in older patients, so I look at age. I do ask about alcohol history or use of other agents. So as we're all aware today, opiates are very commonly used by patients in an outpatient setting. So I want to have awareness of that. Benzodiazepines are commonly used, and then antipsychotics are commonly used in the United States. So I try to get a good history overall with regard to the patient's current cognitive status. I find that patients who are cognitively impaired coming in are more likely to experience delirium. I want to know about their social habits in terms of their use of alcohol or recreational drugs, and then what is their prescribed medication history as well, and put all of that together and then try to establish a plan for the patient after surgery that I set out before surgery, and then relate to the staff as to how we're going to try to manage this patient to avoid their slipping into delirium.
Another curiosity on my part, but does the University of Arizona in Tucson have an elderly ward to recover surgical patients?
We don't have a ward dedicated to that. We do have a geriatric service that we frequently consult, and we have a lot of geriatric patients, so we have a fair amount of experience with that. We have a geriatric service that we can consult, and they're excellent, and we lean on them heavily.
Well, I've got two other clinical conditions that I'd like you to weigh in on, David, and one is you've got a patient who has an esophageal stricture. They're undergoing dilation of that stricture, and lo and behold, you get a call that they have perforated the esophagus. Do you get that call still, or does the GI doc just put some clips on and that's it?
Well, we still get those calls, but I know that we don't see all of those patients because often now they have newer means by which, as you indicated, to address that problem. But in that setting where the patient's undergoing a dilation for a stricture, what I'll do with those patients is obtain a gastrograph and swallow and determine how much of a leak the patient really has. And in most circumstances, in that setting, I find that those patients can be managed conservatively, often do not require operative intervention, and they'll resolve without my having to go in and actually surgically repair the site. If it's a large tear, then I may need to. But in many instances, after the gastrograph and swallow, I'll find that they have a focal leak that doesn't require anything more than placement of a chest tube, for instance, and they don't require direct operative intervention.
Is it still valid that one of the things that helps us make that decision is if the leak is small and it drains back into the esophagus?
Yes. So oftentimes I'll see on a gastrograph and swallow that there's a small collection adjacent to the esophagus, but it's not free-flowing into the pleural space or elsewhere within the mediastinum, and those, I think, can be managed conservatively. But again, I would emphasize this is on a case-by-case basis.
What's your experience with closure by clips when they try this? Is this mostly successful, or is this something that just delays the definitive management?
I typically will get the patient if the clips don't work, honestly. So I am aware in discussions with our GI colleagues that they will use clips, and I don't see all of these patients, to be honest with you. So my sense is that sometimes it is successful. I typically will be asked to see the patient when the clips have not been successful. So my overall sense is that sometimes the clips are successful and they don't require the services of someone like myself. I'm seeing a somewhat select population, those for whom clips have not been successful. But even those patients often can be managed conservatively. Again, this is in the setting of, a controlled circumstance where they're trying to dilate a stricture.
Well, it's very interesting. That discussion was another discussion held by CSAP committees, and nobody had an idea about what the success rate for clips was, and the comments were exactly what you said. Well, we see the population where they don't work, but we don't really know how many patients they work in. So
Exactly.
Well, let's go a step further, and what about Boerhaave syndrome? We talk about this, and it's been around a long time. And is the treatment for this changing? Is this another place that people use clips?
I would say there has been an evolution in how these patients are managed. Now, Boerhaave is a very different circumstance than what I call the controlled dilation of a stricture. In Boerhaave, typically it's an uncontrolled situation. It's as a result of vomiting against a closed glottis, And these ruptures can be significant and often involve significant tissue damage. And these perforations are often quite large and cannot be simply left to conservative management. In fact, I can't remember the last case of Boerhaave I saw that I could manage without some type of intervention. Now, having said that, what we try to do for Boerhaave's today is try to salvage the esophagus if at all possible. And we've really, I think, extended the time frame for which the esophagus can be salvaged, by which I mean even patients who've been perforated for several days before they come to see us, we think we, in most circumstances, can save their esophagus. Well, let me break these patients down into two groups. So early, meaning less than 12 hours, my approach is get a gastric graph and swallow. If it confirms, a large perforation with free flow into a pleural space, those patients I just take directly to the operating room. And then we'll look to do a repair of their site of perforation, then a rotational muscle flap or a pleural flap as necessary to reinforce the closure. For patients who present in a delayed fashion after 12 to 24 hours, I still try to preserve the esophagus. That is, I'm not looking to do an esophagectomy unless there's other significant pathology present, i.e. a carcinoma or severe stricture. But in a patient who doesn't have significant coexistent pathology that requires esophagectomy, then I'll look to try to stabilize the patient. Now, when a patient is presenting in a delayed fashion, they often, by that point, will be septic or have some degree of systemic inflammatory response syndrome. They're not great operative candidates, at least at that time, to go in and have a major esophageal repair. So what we've gone to more often in those patients is try to stent the site of the perforation initially, try to get the patient stabilized, get their sepsis under control, and once we've got that under control, then take the patient to the OR to try to perform a closure over the stent to try to decrease soilage of the mediastinum, soilage of the pleural space, and really close the site of the perforation, leave chest tubes in, establish another source of ventral access, typically through a feeding jejunostomy, and then hopefully have the patient recover and be able to have their stent removed.
And what about these reports that they put the stent in, they have drainage of the left pleural cavity, and they don't have to do anything else? Does that really happen?
That sometimes happens, yeah. If you're working with your gastroenterologist, you sort of can get a feel for which of these patients may be able to be treated purely with a placement of a stent. But in my experience, for true Boerhaave's, where the patient has suffered a rupture of the distal esophagus as a result of emesis, stenting alone without some type of concomitant operative procedure, I haven't seen that be successful in many settings. I have found that more to be successful and more in the setting of somebody, for instance, as we were talking about earlier, who may have experienced a contained, limited rupture as a result of dilation, for instance. But a Boerhaave's where there's significant tissue loss, to have it treated purely with a stent and not require other intervention beyond that, in my experience, has been pretty rare.
We've got one question in CSEP 17 about diaphragmatic paralysis, and it talks about the diagnosis, and the critique talks a little bit about the treatment, but how do we diagnose a paralyzed diaphragm these days, or what is the best way?
Well, that can be somewhat dependent on what you have available at your institution, but the commonly used test is a sniff test, which is looking for paradoxical motion of the involved hemidiaphragm by actually having the patient sniff and then obtaining fluoroscopy. But a number of other techniques, including use of EMG to detect whether or not the nerve is in fact functional or not, CT scans, etc., can be brought to bear on this problem, and so there's a number of different diagnostic techniques which are available beyond the classic sniff test.
But the sniff test means you have to find a radiologist who does that old-time test, right?
That's right, and that's becoming more difficult to find somebody like that. So other modalities, including EMG, CT scanning, et cetera, have started to come in to sort of fill that vacuum.
Now, in the general surgery literature, there's a number of papers now about what to do with that paralyzed hemidiaphragm, especially bilateral paralysis, and trying to get them off a ventilator. Do you have any experience with phrenic nerve stimulation or direct diaphragmatic stimulation in these patients?
So we actually here at the University of Arizona do have experience with that. We actually work with our neurosurgery colleagues who have a lot of experience with this now, and are actually in clinical trials using phrenic nerve stimulation for a variety of treatments, including treatment of diaphragmatic paralysis, as well as novel treatments for heart failure. So that is something we do have a fair amount of experience with and have had success with. So phrenic nerve stimulation is something that should be considered more and more rather than just simply plication of the diaphragm, and something that I would recommend in consultation with the neurosurgeons in your institution to see if they offer that therapy.
One of the problems that's reported, at least, is fibrosis of the nerve related to the stimulation. Is that a problem that you have seen?
It's a problem that I've read about. My understanding is that the newer stimulators have been improved to compensate for that issue that was noticed in the past. That is a real concern, that with chronic stimulation over time you induce fibrosis within the nerve, and then the stimulation loses its efficacy. But the newer stimulators, I believe, have been improved to the point where that's a less frequent complication.
David, I really am sorry, but I see that our time is up. It is always a pleasure talking with you and learning your view on many of these topics that are really problems that all surgeons of any specialty face. So I'll give you the chance for the last word regarding anything on perioperative topics or CSAP audio companion in general. So the stage is yours.
Well, John, thank you for the opportunity. It's always a pleasure to go through these issues with you. You always ask very challenging questions, so I appreciate the opportunity. I would say that for the audience overall, that CSAP is I found to be an incredibly valuable resource tool to address these ongoing changes in surgery. The practice of surgery is constantly evolving, and it's very difficult to keep up with everything that's happening across the spectrum of surgery that most surgeons are expected to be continually masters of. And I can't think of a better resource than CSAP to allow for that. When you consider the breadth of topics covered and the relevancy of the topics covered and the ability of CSAP to constantly keep on top of these changes which are happening, I think it's really a unique, one-of-a-kind resource out there. And I would encourage everyone to utilize the full spectrum of everything around CSAP, the written materials, the audio companion, to realize the biggest impact, because all of us are busy. We all are seeing a lot of patients, treating a lot of patients, and it's difficult to keep up with innovations and the evolution in practice, particularly if they're just a little bit away from your everyday practice and things that you're not seeing necessarily on a regular basis. CSAP can be your resource to really keep up to date on these things that are happening in related fields around you or within your own field, but helping you feel confident that you're always able to offer the best, most up-to-date standard of practice to your patients in the day-to-day delivery of surgical care.
Well, David, thank you for that, and thank you for your contributions to CSAP.
Thank you very much. Really enjoyed it.
That's the end of this session for this category of the CSAP 17 audio companion. This category will continue in the next session.